Hi, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speaker is Dr. Avi Denburg, and his seminar is entitled Social Values and Child Health Priorities, Empirical Evidence for Pediatric Drug Policy. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We also wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speaker. Dr. Avi Denburg is a staff oncologist and clinician scientist in the Division of Hematology Oncology at the Hospital for Sick Children. He has a Master of Science in Health Policy, Planning and Financing from the London School of Economics, and a PhD in Health Policy from McMaster University. Dr. Denburg's research centers on the analysis and strengthening of childhood cancer systems, with a specific focus on issues related to pharmaceutical policy and drug access. He has ongoing collaborations in the field of global oncology with a range of national and international partners, including the Union for International Cancer Control, the World Health Organization, and the Pan American Health Organization. Dr. Denburg is immediate past chair of the Essential Medicines Committee for the International Society of Pediatric Oncology and co-founder of Access to Childhood Cancer Essentials, a global initiative to improve access to essential medicines and therapeutics for children with cancer. He is an expert member of the Pan-Canadian Oncology Drug Review for the Canadian Agency for Drugs and Technologies in Health and the Ontario Steering Committee for Cancer Drugs. And he serves as chair of the Drugs and Therapeutics Committee at the Hospital for Sick Children. Dr. Denburg, it's over to you.
Thanks so much, Andrea. Can you hear me okay?
I can hear you perfectly.
Thanks for that generous introduction, and thanks everyone for joining today. I think it's entirely appropriate that the session was started off with the dulcet tones of Andrea's little one in the background, because I'm speaking obviously about child health priorities today. My passion, my interest of research and clinical activity is children and their health and their illness and how to ameliorate illness in children, and also how to think about kids in the context of health systems writ large and how their health squares with societal values around what we prioritize in our health system. So I'm going to speak to you today about some work that colleagues and I have undertaken to try to better understand the societal values that attach to child health and child health priorities through a mixed methods study. I was conscious, in the context of the rather deflating presidential debate last night and news over the course of the past few days of the COVID situation in our province, that topics such as this might seem as though they pale in comparison in terms of importance to what we're hearing on the news every day. And to some degree, I suppose that's true in the near sense, but I think that this kind of news and the situation we're facing with respect to something like COVID only redoubles the importance of a topic like this, which is really about how we fairly allocate resources in our society. In the context of pitched resource scarcity, and that's only increasing in the context of the federal budget deficit for COVID and other allied pressures. So with that, I'll move into the content of the talk. And I want to encourage people to interrupt me as they see fit and ask questions, because I'd love for this to be as interactive as possible, the venue and the format notwithstanding. So just some front matter, some acknowledgements of my co-investigators on the research I'll present today. I don't have any conflicts of interest, and I have some research funding that's enumerated there to disclose. So in terms of what I'll speak to you about today, I'm hoping to cover at a very, very high level some thoughts around how priority setting or resource allocation is undertaken in health systems, and some of that will be familiar to many of you. What might be less familiar to most is some dynamics around pediatric drug policy and policy making in Canada that I'll cover very briefly. And then I want to spend the bulk of the hour talking about really two intertwined studies that we undertook. I've listed three here, but I'm going to focus on the qualitative case study and the stated preference survey to give a flavor of some of the data that we've turned up in respect of social values around child health and public preferences for resource allocation involving children. Hopefully at the end, we'll have a little bit of time for discussion around the policy relevance of some of these findings. So this slide, which again is a high-level snapshot of where our health system spending is at over the past couple of years from CIHI, will come as a surprise to few of you. We are living through a context of resource scarcity in our health system, if not our broader public policy and society, where costs are really consistently outpacing growth for the past couple of decades. You can see that of the major costs to our healthcare system being hospitals, drugs, and physicians, at least the trend over the past few years, with probably the exception of the past year, has been that drugs have outstripped all other spending in terms of growth per person, not in absolute terms, but in growth per person, and constitute a large and increasing proportion of our healthcare budget. And this stands only to send that into more of a pitched relief. So this notion of personalized or precision medicine, which many of you will have heard something about, which speaks to trying to tailor therapies, interventions, and services to individual patients or specific cohorts of patients, threatens to potentially overwhelm our healthcare system in terms of the resources necessary to deliver those innovative therapies. And we're seeing increasingly that personalized medical therapies or precision therapies in the realm of cancer and of some autoinflammatory diseases is increasing exponentially, with biologics in the drug space anyway accounting for huge increases in costs over the past few years to the proportion of 230% in the last decade and a half or so. So this is going to continue to be a major issue. And this is set against different dynamics in the context of public discourse in our society, where on the one hand, we are increasingly tethered to ideas about innovation in our health system, and on the other hand, strained by and constrained by limited resources. So I'm not sure if this picture will be familiar to many, but this is a young woman by the name of Maddie Vanstone, who suffers from cystic fibrosis and a rare form of it. And she lobbied the provincial Liberal government a few years ago very hard for access to a novel therapy for her specific subtype of CF in the context of a negative funding recommendation at the national and ultimately provincial level. And she was successful in so doing, such that the provincial government, in concert with some other provinces, went back to the table with the pharmaceutical company to try to renegotiate price and access to this medicine. And the reason I put this here is I think it discloses a tacit tension between our social values and our explicit policy choices when it comes to kids. And while this may not be unique to children, it certainly becomes more loaded when children are put in the media spotlight and at the center of public discourse on these things. So I think this is just a nice way to set up discussion around whether or not children are owed anything different in our society, and whether or not any social values that we hold collectively or powerfully in segments of our society need to color public policy in different ways. In terms of public drug policy for children in Canada more generally, unfortunately is a bit of a patchwork scene right now. This slide's a bit dated, but it tries to give a broad sense of how disparate coverage is for children with different diseases and in general terms for drugs across our different provinces. And the other thing I think I just wanted to highlight here is that there is really nothing very specific in most provinces, with a few exceptions now, in terms of child-specific policy around drug access. And this is from the level of our federal regulator through to our health technology assessment bodies at national levels and at some provincial levels and on to public payers. And we can talk about this in more detail. There's obviously some exceptions there, but I think the short point is that it's difficult to make public funding decisions around drug access for children for a variety of reasons, and that we don't take sufficient account of some of the unique dimensions of child health and illness in doing so. And that's what some of this research tried to do. I'll speak at a very high level to some of the drug access challenges for children that currently exist in Canada, and which I unfortunately see every day in my clinical practice as an oncologist. There's a number of health system challenges, and there are a number of challenges that are specific to health technology assessment and the way it's conducted. On the health system side, there are big issues with the political economy of drug development, research, and funding for children. Simply put, most industry firms are not incentivized sufficiently to create and test drugs for children for most diseases by the simple dint of market dynamics and calculus. It doesn't pay as much to treat children if the disease is rare and if the indication for treatment is relatively short. With, again, some exceptions. At the level of our federal regulator, in sharp contradistinction to a couple of others, particularly in the US and in Europe, there is very little to incentivize or compel manufacturers to submit evidence for pediatric indications when putting drugs on market in Canada. And that's something that we may circle back to. And then at the level of health technology assessment, the way that HTA submissions are done, which are predominantly manufacturer driven, and the way that priority setting is undertaken for which technologies get reviewed by HTA bodies, lacks any consideration of unique dimensions of child health and illness. There's some issues on the HTA side as well. In particular, these center around evidence and economics, but there are ethical dimensions as well. In terms of evidence, the hierarchy of evidence-based medicine tells us that a randomized controlled clinical trial is sort of at the apex. For many childhood diseases, it's very tough to do RCTs as a consequence of the numbers affected with a given illness, and to some degree with difficulties historically with trial enrollment in children. So issues of disease biology and epidemiology play into limitations there. And then in the economic realm, the ability to capture life course dynamics, late effects from therapy, child and family utilities and preferences for treatment, and how treating a child might impact the larger family, and then some other externalities all impact upon the ability to accurately ascertain what the costs and benefits are for treating children with given diseases. And then as you'll see through some of my talk, there are some procedural, substantive, and spatial issues more in the normative space that pertain uniquely to children that aren't thought through at all. And all of that amounts to a lack of coherent, consistent, and equitable drug policy for children in Canada, at least I would argue. So the aims of the research that I'll present are the following. The first study, which was really a literature review, a critical interpretive synthesis, in which I won't spend too much time on, aimed to review and critically analyze the literature on the moral dimensions of child health and social policies. So I'm happy to speak offline with anyone who would like to talk in further detail about that. But the two studies I'll center on were this second qualitative case study that aimed to probe the complexities of health technology assessment and drug policy for children, with specific emphasis on our context in Canada and in Ontario as a unique case study. And then finally, to generate empirical evidence on societal preferences related to the allocation of public funds for child health interventions. And that's a third study that took the form of a stated preference survey that I'll speak to last. All of this began with the premise that we really construct ideas about childhood in our everyday images of children, in how we speak about them, and in how we invoke those images and ideas in our policymaking. And I think there's a quote by these two sociologists, Moss and Petrie from the UK, that captures this sentiment nicely, which is that public provisions for children are inextricably linked with how we understand childhood and our image of the child, which are contestable constructions produced in the social arena rather than essential truths revealed through science. So On to the first study I'll speak about, which is this qualitative piece of work. And we called it "The Problem is Small Enough, the Problem is Big Enough." And I'll tell you why. So the main objective and methods of this study were as follows. We sought to explore the determinants of public policy decisions on pediatric drug funding in Canada, undertaken through a grounded theory approach. We conducted 22 in-depth interviews with a range of stakeholders, either involved with or impacted by HTA for child health interventions. And these included parents of children with cancer or other chronic illnesses, health professionals, national HTA professionals, and Ontario policymakers. So this is a busy slide trying to capture and encapsulate a number of the major themes and categories that emerged through these interviews, and I'll try to walk you through some of these in the slides that follow. But in essence, the major categories that bubbled to the surface through these interviews were ideas and concepts centered around the technologies themselves, so either the health technology assessment enterprise or process, or technologies as drugs more generally, and then also ideas about society and the societal overlay and interface with HTA and with those technologies. And these spanned all the elements of HTA along the production line of HTA, if you will, from assembly of technologies for review through their frank assessment and into their the uptake and integration of recommendations from HTA bodies into the health system and its policies. And 3 species of values also emerged that tagged to these different kinds of themes, and those clustered into procedural values, structural values, and sociocultural values. And I'll speak to all of that in the slides that follow. Suffice it to say, I'm trying to cover a lot of ground in this talk, and if stuff's not clear, I'm happy to speak with folks afterwards in more detail, and I'm happy to take questions throughout. So Andrea, please feel free to interrupt me. So this first cluster of ideas, or first theme around health technology assessment specific to children, centered on this notion of assembly, which really speaks to how technologies are framed and packaged for consumption by HTA bodies and consumption by the public. When I say consumption, I mean their apprehension or understanding of their potential value, of their meaning, of their use, rather than consumption of drugs per se. So a lot of this centered on priority setting. How do we make decisions about which health technologies we should even assess at the level of HTA nationally or provincially? And the participants to this research identified a number of limitations in respect of the typical prioritization criteria used by HTA bodies when thinking about children. So for instance, things like budget impact, or disease epidemiology, disease burden, or economic impact at a societal level, or the strength of the level of evidence. All of these sorts of things are prevalent criteria used across HTA bodies in different jurisdictions that tend to bias against children when prioritizing technologies for assessment by HTA bodies. And a number of the participants to this research identified just that. One comment from a provincial policymaker was as follows: if your view is to have a look first at the most common cancers, 100% of the time, children are going to be at the back of the queue. So there was an express need to consider some of the upstream impacts of priority setting principles on the downstream selection and assessment of health technologies for children. There were a number of process limitations that participants also noted in respect of health technology assembly. And really, a lot of this centered around the dominance of manufacturer submissions. So in our system, most of the time, most health technologies that come to national and provincial health technology assessment bodies come to those fora because they are submitted by manufacturers for assessment. This is more the case at the national level than at some of the provincial levels, but nevertheless, there is definitely a dominance of industry submissions driving our priority setting. And there are concomitantly weak mechanisms to facilitate alternative source submissions by clinicians, by members of the public, by patient groups, etc. And this creates an inherent limitation to pediatric drug assessment because of the weak market incentives I spoke about and the added costs of drug R&D in children. Some proposed solutions there were investment to support provider submissions, pediatric indication requirements on HTA submissions that come from manufacturers, and some spoke to the need for a pediatric HTA watchdog organization that tries to police some of these priority setting mechanisms and process issues. So a quote that relates to this from a provincial policymaker: "The one policy thing that really bothers me in drugs is it relies almost universally on the manufacturer putting something forward. So the biggest issue I find in HTA, and it's particularly relevant to pediatrics, is a lot of things never actually come forward for HTA." Oops. So we move on to assessment, which is really the nuts and bolts or the meat of health technology assessment, where evidence and economic issues and patient values get considered in making recommendations about which drugs or health technologies to fund. And here, real limitations in evidence were noted in respect of childhood health technology assessment by participants. So I spoke to the epistemic hierarchy of evidence-based medicine, and many noted that for children, this is a bias that really constrains the review of pediatric technologies because of limited evidence in randomized form that proves efficacy. And so this is somewhat coincident with issues that many rare diseases encounter, noting that most pediatric diseases are in fact rare, but it's not entirely the same. And there was a call for greater recognition of the value of diverse forms of evidence, the need to consider clinical and societal context when making some of these decisions, in addition to just p-values and hazard ratios and strengths of level of benefit. And one health professional said, small numbers, small bodies, long outcomes, there has to be a different perspective. A parent had a very, I thought, poignant quote in saying, when you have children who are being put into very specific baskets of their genomic and genetic markers, and this is this precision medicine concept we've spoken about, the problem of the uncertainty of the evidence is really going to hit an apex. It's going to mean looking at clinical trials and looking at evidence very differently. We're going to have to see a major shift. So there was a call for innovative ways to produce, incorporate, and assess pediatric evidence. And some of those suggestions were for things like basket trials, N-of-1 trials, adaptive pathway designs in health technology assessment, and things of that sort. I recognize I'm glossing over what those things mean, but because of time, I'll do so. And again, happy to speak more to these in the question period or separately with people. And then so quickly on the economic front, again, I mentioned difficulty in current economic guidelines and models to undertake life course modeling that really incorporates late effects and health state transitions in terms of latter health for kids. There's almost no ability these days to do preference elicitation from children or of families, at least in the context of current HTA practices. There is so being developed in academia. And there was a lot of thinking around how best to value different times in the life course and states of health for children. So ideas like sensitive periods in social emotional development and their outsized importance to childhood across to people across the life course, and ideas about fair innings. So making sure everyone has the same chance to live the whole arc of a life were things that came up in respect of doing economic evaluation for children. And then finally, with respect to how these recommendations get taken up and integrated into our health system, there was an emphasis really on means above ends. So people spoke again to the need for and challenge of integrating diverse forms of evidence in health technology assessment, including things like deliberative public engagement. And they spoke, many of them, to the potential value of a distinct framework for child-focused HTA that might elaborate or emphasize a few different principles or values or processes than regular one-size-fits-all HTA as is currently practiced for all technologies. And then finally, I recognize this is a bioethics talk, so there might be interest in thinking around some of the values that, again, bubble to the surface in the context of these interviews. I won't have time to delve into all of them. There was real richness here, but I want to enumerate them at a high level. So really these, again, clustered into procedural, structural, and sociocultural values. Some of the procedural values will be familiar to many, so things like the process of HTA for kids needs to be fair, it needs to be transparent, it needs, in some respects, to be deliberative, and it needs to be participatory. And one could argue that these are the same kinds of procedural principles that may pertain to HTA writ large. There were some nuances there in some of the interview data, but I won't belabor this because of time. I think where there was more difference was in the structural and sociocultural values, and I've intimated some of these already. So the notion of fair innings, again, that everyone should have the same chance to live the whole arc of a life was something really that predominated in the interviews. Notions of unmet need in the context of disease rarity and in the context of children being under-prioritized for health technology assessment more broadly really came to the fore. As did notions of family that are currently underrepresented, if represented at all, in the way that we think about whether or not technologies have value in our society. And then finally, on the sociocultural front, there really did emerge a sense that children are different in some ways. So a notion of distinction, and that difference rests on fundamental societal values. So, one parent said societies are judged by how they treat the elderly, the infirm, and the children. When the infirm are also the children, I think there's a double ethical responsibility by society. And there was a nice quote from a health professional that tagged well to this idea about fair innings, which stated that before we get some people to move from 80 to 90, we should get everyone to 20 first in terms of fairness. Before everyone has two houses, everyone should have one place to live. There were ideas about equity and how vulnerable children in our society need some extra protections in relation to thinking about technologies that would be valuable for them. And there were ideas about how these ideas might vary across different cultural contexts. But again, I'll save that for future discussion. So some key high-level messages from this tranche of the study. The first was that there were real differences of context and substance when thinking about child drug policymaking and child health technology assessment. And those differences span the production, the evaluation, and the use of child health technologies. And that these distinctions really reveal some shortcomings about the way we currently do HTA and the way we make drug policy for children. And again, the second, I think, major takeaway message from this was that there was a distinct typology of social values that emerged that have relevance to drug policy, but also potential relevance to policymaking in at least the health sphere for children more broadly in a variety of health system contexts. So I'll move on now. I realize this is a bit of a breakneck pace to the next and final study, which was an attempt to understand, rather than the granular in-depth approach to eliciting individual perspectives in the prior study, to understand at more or less a population level what public preferences are related to health resource allocation for children. And to do this, we undertook a stated preference study of the Canadian public. So again, I think this will come intuitively to most. There's a growing recognition of the relevance of societal values when we're doing health system priority setting or resource allocation. In other words, knowing what the public thinks about this and what our underlying values would say is important to making these decisions. That's increasingly accepted by policymakers and the public alike. Really, to date, there have been two ways of doing this. The first has been with population-based surveys, so sending out surveys to large swaths of the population that are more or less representative and trying to ascertain how the values shake out. And the other major way has really been a much more invested and granular attempt at deliberative public engagement with varied publics. There's obviously a broad divide, and each of those has its pros and cons. What we tried to do with this study is get a little bit of the best of both. So we undertook a population-based survey, but within it we nested a deliberative experiment, so a moral reasoning experiment that we actually subjected participants to in a randomized fashion. So this was sort of like a randomized clinical trial, although not for a drug, but for an ethical intervention. And again, we focused on children not only because it's something that I care about, but also because age has been recognized by many other scholars and policymakers as a morally relevant variable in these kinds of decisions. But unfortunately, there hasn't been much inquiry into this in respect of kids specifically. So we know a lot about, increasingly more about allocative preferences in different societies generally, but usually in adult populations and not so much regarding children. So there was a need for knowledge there of specifics around child-adult trade-offs to get more rich data to inform policymaking on this front. So again, our objective was to test societal preferences for health resource allocation between children and adults and assess the impact of a moral reasoning thereon. This was a stated preference survey of the Canadian public, population-based sample that we used a marketing research firm to gain access to through email invitation and was administered online. And the design took the form of some clinical vignettes that grounded choice scenarios, and I'll explain that in a sec. And then also this randomization of one half of the experiment of the cohort to a moral reasoning exercise. And we undertook some descriptive and inferential statistics to try to make sense of our data. So here's a sample clinical scenario that we subjected participants to. You can see there are two drugs, drug A and drug B. This is highly a heuristic, really. It's reified. So on the one hand, there's a new therapy for acute child malignancy, and on the other, drug B, there's a therapy for acute adult malignancy. The situations or scenarios are otherwise identical. Both the patient who is 10 years old and the patient who's 40 years old can be expected to be cured and live to average life expectancy if they receive this therapy, and both will die within 6 months without the therapy. But the only difference obviously is the age. On the one hand 10, and on the other hand on average 40. And we asked participants to take a health system administrator perspective, saying the health system can only fund one, which should it fund, and ask them to state their strength of preference for one or the other by sliding the bar between -5 or -5 and +5, with 0 being no preference, fund either drug, or equal preference, -5 being definitely fund drug A, and +5 being definitely fund drug B. And this was a continuous scale. And then, as I mentioned, we randomized half of the participants to this moral reasoning experiment. From this study I just spoke to you about, the qualitative study, as well as the antecedent one to that, the literature review, we drew some values related to health system priority setting generally and health system priority setting for children specifically, and tried to create a list of principles that encompass those values with explication of each of them. In other words, descriptive statements so participants can make sense of them. And we asked participants to select the top 3 of those 12 that they deemed most relevant in each clinical vignette or each scenario. We didn't split them out in general and child-focused terms for participants, but I did that here so you can get a sense that we included both values or principles that you might argue are more generally applicable and could potentially bias participants towards allocation to adults, or would potentially privilege adults, things like personal responsibility, economic productivity, strength of evidence for efficacy, notions of equality. And then we had a bunch that we thought were maybe more child-focused, like considering the future potential of the recipient, considering notions of fair innings, considering things like dependency on others or vulnerability, considering things like specialness or distinction. And here's just a little flavor of what some of these descriptive statements look like. So if you look at the top one, the first is this principle of efficacy, or evidence of efficacy, even more specifically. And the statement is fund treatment based on evidence that it works. And our descriptive statements included fund treatments best proven to be safe and effective. And importantly, to give context, we also specified, since it is harder to study treatments in children, evidence is usually stronger for adult treatments. So you can see how that one might have inherently privileged allocation to adults by virtue of the way we frame the principle. By contrast, help everyone to live a full life. We specified this would give the younger patients a chance for a full life. The older patients have had their turn. So if they felt that principle was most relevant to making a decision in a given scenario, that would privilege an idea like fair innings. So we had a number of aims. Really, this was in the main to understand the direction and strength of societal preferences for health resource allocation between kids and adults across these treatment scenarios. We wanted to understand what this moral reasoning exercise would do to the expression of those preferences. And we wanted to understand what sociodemographic factors might significantly impact those choices. We also looked a little bit at testing preferences from an assumption of neutrality from -0.5 to +0.5, so we could better get a sense of how strong preferences were. And we wanted to see which principles participants privileged most. So just because of time, I'll try to go quickly through this. We had a nationally representative sample of a Canadian adult general public. And our sample, this is a super busy slide, but I'm just going to call your attention to a couple things. This is basically to show that our sample largely reflected the Canadian population, with the exception that it was a slightly more educated sample. And there was an ever so slight shift to higher income brackets, although the brackets are different across Canadian stats norms and the way we segmented them in our trial. So this is probably not hugely significant. So now to some of the fun stuff, the results. This is a slide, and I apologize for there being lots of numbers here, but I'll try to walk us through them. This is a slide of the mean preference scores by experimental group, and it's just the raw data before we tried to correct for confounders. You can see that across the control group, remember, negative numbers means stronger preference for children. There is uniformly a stronger preference for allocating to children across all of the control groups. In other words, across all the scenarios, in those that did not receive the moral reasoning exercise, everybody preferred to allocate on average to children. By contrast, in the intervention group, you can see that in statistically significant fashion, even where there was an aggregate preference still that retained for children, where the negative numbers are, in all instances, the direction of that preference moved towards allocation to adults. In some, like the chronic disease drug situation, it moved frankly to allocation, either equally or slightly to adults. And in our liver transplant, cancer therapy, palliative care, and eating disorder scenarios, the strength of preference for children was attenuated in each instance when participants were subjected to this moral reasoning intervention. And I have to say off the bat that this ran counter to the hypothesis that we stated a priori. We thought this moral reasoning exercise might induce stronger strength of preference for children. And this is that represented graphically. I'll try to go quickly through this stuff. So this is our multiple regression mixed model that basically just tries to look at this stuff again across groups, across scenarios, and the interaction of those two things, and to try to control for confounders and other covariates like sociodemographics. And what you can see here is, again, that when all of that is controlled and corrected for, that those subjected to the moral reasoning intervention, that tended to induce a stronger strength of preference away from children. So that might still have been a preference for children, but it was weaker in aggregate than in the control group by this amount and in a significant way. You can also see that there are a couple scenarios for which that strength of preference for children stayed pretty strong, albeit slightly less so, despite the intervention, and in the boxes I've highlighted as against our chronic disease drug scenario as a referent. And I have some thoughts about why in the cancer therapy and eating disorders treatment scenarios, the strength of preference for children was highest, but I'd be interested to discuss that with folks. One hypothesis we had was that these were the only scenarios in which the benefits that might accrue from the intervention would accrue across the life course without time-bounded effects. So you remember I showed you the cancer therapy scenario. the child in the scenario was 10, the adult was 40, both would have been cured and both would have lived their full life expectancy. So the aggregate benefit to each in terms of life years would have been far greater in children. And the same story was the case in the eating disorders scenario. By contrast, in the chronic disease scenario, in the liver transplant scenario, and in the palliative care scenario, we bounded the amount of benefits accruing to both the adults and kids, and that might have accounted for less strong strength of preference for children in those scenarios. You can also see that if you were younger, you tended to want to prioritize to children more strongly than if you were older, which is perhaps intuitive, and also potentially intuitive if you were a parent, you wanted to allocate to children more strongly than if you were not. This is just looking at these data again in a slightly different way, looking at the deviation of preference scores from 0 between the groups. And again, you can see that across all the scenarios, the difference was in a positive direction as a result of the intervention. In other words, less strong strength of preference for children and those subjected to the moral reasoning experiment, with, again, as you can see, stronger, still retained relatively strong strength of preference for children in those two specific scenarios, cancer therapy and eating disorders treatment. We also wanted to look again at neutral responses across scenarios. And here you can see that in the intervention group, far more people were neutral than in the control group by percentages. Still, overall in both, most people did have a preference. In other words, it wasn't neutral, but there was more neutrality of preference in the intervention group. And we looked at this with a generalized estimating equations model as well, looking at odds ratios. And you can see, again, that specifically in the scenario-specific ones, when looking between intervention and control, the odds of having a neutral preference were higher across all scenarios in the intervention group. And this is, again, just representing that same thing graphically. So you can see, again, that in significant fashion, the odds of preference neutrality were greater in the intervention group. So I recognize we're running short on time and I'm almost done. This just gives you a list of the participant selection of allocative principles by each scenario and overall. Really interestingly, you can see that despite the variance in choices, despite preference for children in the control group uniformly, despite retained preference for children in a couple of the scenarios, people tended to pick equal treatment as the overweening or predominant principle by which they made their decisions in the intervention group. And then the next most prevalent principles were relief of pain and suffering and risk of dying, so a notion of rule of rescue. The idea about capacity to benefit longer, vulnerability, levels of evidence, fair innings, those were all prevalent, but less so than those first three. And I've just highlighted in green or in red those that in statistically significant fashion varied in some scenarios. So you can see, for instance, in the palliative care scenario, there was a statistically significant increase in those picking equal treatment and relief of pain and suffering as the most important principle, which is perhaps intuitive. Conversely, in the cancer therapy and eating disorders treatment scenarios, you can see that the capacity to benefit longer and notions of vulnerability and fair innings tended to predominate more. So some aggregate findings. We saw from all this and surmised that really there is actually an aggregate preference for allocation to children as compared to adults, which is perhaps not overly surprising. Andrea, I see that you've popped back on video, so I know that's my warning to shut up soon and let people have a chance at me. So I'll just summarize quickly. The other thing I think we saw is that the moral reasoning intervention had a really interesting and I think unique impact in that it weakened the preference for allocation to children in the intervention group, despite significant retention of that preference in those specific cancer therapy and eating disorders treatment scenarios. There was a greater likelihood of preference neutrality in the intervention group. And again, the top three principles were equality, relief of suffering, and rule of rescue. And again, we saw that being younger and being a parent was associated were associated with stronger allocative preference for children. So there's some complicated ways to try to explain all of this. I'm happy to start into that, but I think this might actually be a nice place to pause and think a little bit about what all this means, and welcome some comments and thoughts and questions from all of you, because I think there's a lot of loaded stuff here, and I'd love to unpack some of it together.
Thank you so much, Avi. So as mentioned, it's now time for questions and discussion. I'll start off, Avi, by reading the first question out to you. So this question is as follows. I'm wondering if in study 3, the incidence of the cancer in the population was considered. Pediatric cancers are in general quite rare, whereas adult cancers are less so. Perhaps there'd be a greater overall benefit in targeting the older population compared to adult cancers. So I guess the question is whether incidence of the cancer in the population was considered.
Yeah, that's a really interesting question. And I wish we were all together in person, because I'd love to chat about it in a little bit more of a discursive way. But the short answer there is no, it wasn't. I don't think it was considered overly. And the reason for that is these scenarios were really individualized in the sense that we didn't ask participants to take into account aggregate population level benefits. And this is the way health technology assessment to some degree is normally done. We look at benefits that accrue to individuals in terms of quality adjusted life years, usually at the level of an individual, and don't necessarily add that up over the number of people impacted. So it's utilitarian in the sense that you try to maximize the amount of life years, arguably, for individual people, but in HTA, you don't necessarily add that up across a population. Now, that's an easy answer. What participants were thinking in the context of answering that question, I don't know. They may well have been thinking just what you asked, that cancers in adults are much more common. So if we privilege funding to adults, we'll help a lot more people, albeit for shorter amounts of time each. But that's not the way the questions were framed anyway. And in fact, I guess the outcome, one would think, bears out the opposite, right? They tended to privilege children in that scenario. And I think they did so intuitively because they recognized that children would live a lot longer if they were cured of their disease.
Thanks, Avi. So I'll move on to another question. So in study 2, you mentioned the relevant values on one of the slides. And in the third column over, you noted something about cultural considerations or culture.
Yeah.
I was wondering if you could speak a little bit more about this culture piece.
Sure, that's a great question. I think this is the slide to which you're referring. The cultural piece was fascinating. To be perfectly honest, this was something that I really would love to explore more, and I think deserves more exploration. I don't know who asked the question, but it's possible that's something you've done or something you're thinking about doing. I'd love to talk more about that, because while we heard a little bit about this, I don't think we heard nearly enough. Really what we heard was that from a few participants, that they recognized, they had a flag up for potential cultural difference. So they recognized that while many societies, and arguably our society, in most of its instantiations and in most of its specific, I suppose, groups, would privilege children as special, would see them as vulnerable, would see them as in need of unique protection, or deserving of thought around maximization of potential. So in some way would see children as distinct and unique, but that might not pertain across all cultures. So that even within Canada, there may be cultures or elements of our society that would privilege allocation to the elderly and think something very specially about elderly populations and value them particularly, not necessarily above kids, but perhaps in equal measure, or perhaps in some instances above for a variety of deeply held cultural reasons. And that beyond Canada, across the wide array of different cultures that are out there, that there may be different ideas about the importance of children, the importance of very young children as compared to adolescents, the importance of children as compared to young adults who might be productive and economically contributing. So I think it was just a flag mainly put up that that variance might exist, but we didn't get a lot of data on specific variance and how that plays out in different cultural contexts. And I think that's a product of having really focused on Ontario as a case study and not having probably a wide enough sampling frame to capture all the views there.
Okay, that's great. So move on to the next next question, and I'm told that I can actually read out the names as well, so you know who this is referring to, since their names are being captured on YouTube. So I think that is probably correct. So this question comes from Randy, asking, can you speak a little bit more about the cultural diversity amongst the participants, wondering how generalizable this might be across the diversity of Canada or even Ontario?
Thanks, Randy. That's a great question. I have to say that that's one element of this I think doesn't do it full justice, this issue full justice. And I think this sort of tags to what I just said about what we heard about culture. The sample was not as diverse as it could have been in terms of representing all sectors or elements of the Ontario populace or the Canadian populace for sure. We focused mostly on role diversity rather than cultural diversity, or ethnocultural diversity, or religious diversity. There was, I think by dint of luck, frankly, some ethnocultural and religious diversity within our sample, but that wasn't sought. And perhaps that should have been. Really, we focused on a diversity of roles, as I've said. So I don't know that any qualitative piece of work is generalizable to any broader context. And this piece of the work didn't claim to be generalizable necessarily. I think there are some ideas that are probably broadly resilient or relevant across different kinds of publics and different kinds of jurisdictions. But I wouldn't say that this exhausts this issue at all. And I wouldn't say that it's easily generalizable, because I think there's lots of other views out there that we need to incorporate. So maybe we can do some of that other work together.
That's great. So unfortunately, just given the time, Abby, it is time to draw today's seminar to a close. I do have a couple of announcements to make before we thank you, Abby, thank our speaker. So our next seminar will be on Wednesday, October 7th, where Sydney Campbell and Franco Carnaval will be presenting on injustices faced by children and youth due to COVID-19 and ethical analysis. So you can sign up to receive the registration link via our weekly seminar reminder email at jcb.info@utoronto.ca. CSB students who are enrolled in the CSB student seminar course, please comment in the chat box on YouTube that you are present if you are. And Abby, on behalf of all of us, I just want to thank you very much for your incredibly interesting and thought-provoking presentation. I and everyone else watching, I'm sure, very much appreciate it. So thank you.
Thanks, Andrea. It was a privilege. Thanks everyone for joining.